Good afternoon, everyone. We welcome you once again to our webinar. So this is going to be the second WBMT hosts workshop webinar for the Nigerian BMT team. As we all know, this webinar is a follow-up to the workshop that held on the 16th and 17th of November 2023 for the Nigerian BMT team and every other healthcare worker. And we decided to continue this series with a webinar. WBMT has graciously contributed and made this webinar possible. We had the first in April, and this is May. We're having the second episode of the webinar. So we're going to have two distinguished speakers talk to us today from their wealth of experience in transplant. And first of all, we're going to be having Mrs. Reggie Bekledin. She is the chair of WBMT Nurses Group Committee. Prior to that, she was one of the pioneers in the establishment of the Eastern Mediterranean Blood and Marrow Transplantation Group, the EMBMT, and became the EMBMT Nursing Group Chair. She also founded the Unrelated Stem Cell Donor Registry in King Faisal Specialist Hospital and Research Center in Saudi Arabia. In the past, she was an active member of different international societies, such as the European Society for Blood and Marrow Transplantation and the National Marrow Donor Program, as well as the World Marrow Donor Association. She has about 40 years of work experience, and this was largely in a BMT unit. So she worked as a BMT nurse, a BMT clinical nurse specialist, and a BMT coordinator. With her rich experience and expertise, it is really a privilege for us to have Ms. Reggie to present to us on the topic, understanding HLA typing and hematopoietic stem cell transplantation. So I'd like us to welcome on stage Ms. Reggie Bekledin. I would like us to pay close attention. If you have questions for her, please keep your questions in the question and answer section. It will be responded to at the end of the session. Sit tight and listen well. Thank you.
Thank you, darling. Thank you. Thank you. Blessing. I'm really very, very pleased to be again with you guys. And today, as you said, you know, the HLA typing and understanding the HLA typing was one of the, you know, subject who has made me love and like the bone marrow, the bone marrow transplant there. And I have seen it over the years, how the evolution and the revolution as well because of the HLA typing. So you can see it also understanding the HLA typing. Is it how it's not coming? So I'm going to give you an overview of the HLA typing, and but before I really start to talk, I just want to define the HLA typing. So HLA, it's a human leukocyte antigen and typing, and of course you have to know that it's a genetic test. It's been used to match a patient and donor for hematopoietic stem cell, cord blood, or any other organ transplant. And the HLA, they are proteins. We call them also markers. You found them on most of the cell in your bodies. Your immune system use this marker to recognize which cell belongs in your body and which not. So after saying this, to define this HLA typing, so the overview of the HLA and the impact of HLA, of course, it's going to be the impact on allogeneic bone marrow transplant. So this, as I said, and I will repeat it again and again, HLA will apply always to allogeneic bone marrow transplant. We need to identify an appropriate hematopoietic progenitor cells donor. And this question is, who can serve as a donor? And the answer, it's easy. It has to be a compatible HLA donor. So HLA match equals genetic match. So we need to determine the most genetically compatible donor to show the compatibility between the donor and recipient, and the best matching, the most indicator of transplant outcome. So the implication for this, for the bone marrow, and when we have the HLA, matching for HLA decrease the probability. Always remember this, the graft versus host disease, the graft rejection, and the transplant-related mortality. The HLA, as I said, and the immune system, the HLA are the antigen. And as I said earlier, it's these proteins, they are found on the surface of the white blood cell count, major component of the immune system. Immunological surveillance system, of course, as you know, it's recognized self from non-self. And this is unique immunologic fingerprint. So immune system stimulated and foreign matter like donor HPC. So the HLA, when you look at the family, it's genetically determined. We always say, I know where I'm coming from, you know, we inherited from our parents. Sorry. And the siblings, we always get inherited same HLA antigen, and each individual inherited HLA from his mother and father. And of course, it will be always, always the first choice donors. Here, I had just have this, you know, I always said to people, we always get 50% of from our father and 50 from our father. We have 20 from their mother, the 23 chromosome. The father will give us 23 chromosome. And each individual, and we'll get the full 46 chromosome. So that's why this is a very important. When we do the HLA, we always look for where, I always say, where I belong. So most of you guys, you have seen HLA typing result. We always have the HLA resulted divided into two. You have always the class 1 antigen, and it's the famous HLA A, B, C, and just down on the side, the HLA class 2 antigen, and you have the HLA DRB1, the HLA DQ, and DP. Of course, since then, all these years, as I said, so much revolution and research, and we have so many antigen now added to this, you see, so we need to do another presentation only on this antigen, and always to remember the minimum HLA typing to evaluate a donor and patient. It's always in the past when we were doing at the beginning, it's, I'm talking very long time ago, and we have done this with the cord blood. So it's always to have A, B, D, R. At that time, we were looking at this. So the HLA inheritance, where the gene are inherited in grouping from each parent. The parents, of course, are haploidentical to the children, and we know, so we don't have the same, you know, from the father and the mother, you can see. And sibling may inherit the same haplotype by chance, or may inherit one of the other three combinations. There is 1 in 4 chance that any two siblings will be HLA match. So you can see it here in this graph. So let me put it here. So when we look here, you can see you have the father, the ABDR, here, and the mother, she's here. So with the HLA, see, if we look at the 6 out of 6 here, HLA match, so you take the patient, he's here, and you can see here these siblings, he will be matched. He will be 6 out of 6 with the patient, and the haploidentical will be sorry. You can see it. I will send you. I have attached document on this to explain all these graphs and to make you understand, and the complete mismatch. Of course, when you see this, there is no chance this patient will be the donor. This sibling will be a donor. So. The association, when we don't have a match donor, we always go to the match related donor, the MAD, if no sibling. And the word, the WMDA association, so we usually, when you are a big transplant center, we always are affiliated to such association. And MDP, I have been a member for more than 20 years. It's a very nice place as well when you are looking for donor. DKMS, of course, it's one. I remember starting with them when they have only 50 donors in their association, and they became one of the biggest association and donor center. And cord blood bank, there are so many over the world of a cord blood bank. The HLA ethnicity in match-related donor, certain HLA haplotypes are seen more frequently than others in the population. That's true. With the Caucasian white population, the haplotype HLA A1, B8, D3 occur with high frequency. And this for the DRB1, O3, O2 will also be found in the African population. I have talked to this because being so involved for many, many years doing blood donor search, blood search for patients, so you learn how to recognize when you have a donor, where he's coming from. So when we don't have a suitable match-related donor, so we have this, as I said, the alternative donor. We can also get haploidentical family member. So this, we also have started this program, and it's working very with 2 or 3 mismatch antigen. You can do an haploidentical when it's a donor, family donor. So we do also the autologous when we don't have chance to have a donor for an allo. As I said, we can do partial match a related donor. 5 out of 6, it's unrelated. It's very difficult. You have to be very careful. Partially match-related donor, 3 out of 6 to 5 out of 6. It's again very, very difficult. The umbilical cord blood, 3 out of 6 to 6 out of 6. So we have done it. So it is doable, and this is the unrelated cord blood, but we can have also family, they store their cord blood in case one of the child needed it, and they will use it later on. the donor and identification when there is more than one donor. So this is when you are lucky, so you have more. So we always look at the age. Of course, you take always the youngest viral status, and we do all the viral blood tests, the sex, the number, the parities. You know, if it's female donor, we will look at how many pregnancies she has. ABO, it's better to have the same ABO, the race, yes, yes, the weight, the size, the venous access, the willingness to, what is that? The willingness to donate, and then the cell dose. It's when we talk about code. Donor identification obstacle, we have always, we look at the degree of HLA match. So when we don't have any sibling, we, as I said earlier, also we just go and search with other registry, because we always do that when we don't have a donor. Before we go to another mode of transplant, we always try to immediately to look for a donor with a registry, WMDA, ZKD, you know, DKMS, NMDP. The only problem that's when you do search, it takes so many weeks, not months. At that time it was, but it takes time to do. When you found the donor, you have to do the workup, the consent. It takes time. And when you are looking for a cord blood, so you have also to get the enough stem cell for your patient, if it's an adult patient. So sometimes we have to do multiple cord blood to be able to do transplant. So we have the minority patient, and the timing, as I said, when you do that, the timing and the disease, the disease, when you have leukemia patient, believe me, you have to be very, if he is lucky, we can find a donor very quickly, because otherwise the patient, the disease progress before we found the donor. So how we do this, it's done, of course, at the lab, and it's a blood test. It's, you know, it's always, or most of the time, it's peripheral blood. Sometimes when we, the buccal swab, this is for when we do the donor registry mainly, and skin biopsy, this is very, very rare. So the method, how it's done in the laboratory, and it's genotype, and we have a type how we do so, DNA or molecular typing, when you will be starting and doing this, and it can be, and if you have a good lab, so we have the result by low resolution. So when you know you've been doing transplants, so of course we are looking for the high resolution, because we have all our allele level type, and it's a good result. And so of course it's done as a peripheral buccal spot or skin fibroblast, but it's very rare as well. So thank you, Guy, for this HLA typing. I hope you got it all. Do I have to?
Thank you so much, Lady Ma'am. It was so explanatory, very clear. Thank you so much.
Thank you, darling. Okay, we go to the next. Let me go to my next presentation. Okay. Okay, so the next here presentation, we will be talking about the hematopoietic stem cell transplantation. It's the type, source, and the indication. So this is very important. So let us just talk about history. The same, you know, this this transplant and business has been bothering and doing so much search so very early, and after the Second War, because there were all these bombing and there were, you know, so many experimentation has started from that time. That's why in 1949 they have experiment on mice with little doses of irradiation and see what is going to happen. In 1951, radiation protection provided with infusion of a twin marrow. And in the mid-50s, replacements of damaged hematopoietic system with donor cells. So, I am sure you have heard why it did not work all these years, because something was missing in this, in trying to get this patient transplanted. In 1959, the first attempt to treat leukemia using high-dose chemo followed by syngeneic transplant. In the 1960s, so major histocompatibility complex. This is a test we were doing. I remember I have a stat, I knew this. It's very bad to say I'm very old, but you know, in the mid-70s, we were still doing this MSC to look, you know, for the to look for a donor. So many early transplant unsuccessful because of poor engraftment and disease progression. In late 60s, the first successful allotransplant for leukemia, they did it. 73, first unrelated transplant was performed, it was in the States. And 1970s, we did the autologous transplantation for lymphoma, performed and became widespread during all the 80s. And after that, it went just all over. In 80s, the very famous peripheral stem cell transplant were successfully performed. And in 1988, unrelated cord blood transplant was also started and successfully. It was done also MD Anderson. So hematopoietic stem cell transplant is the transplantation of hematopoietic progenitor cell, which have the ability to proliferate, repopulate the marrow space, and mature. Blood count and immunity are reestablished and recover when the mature blood cell enter the blood stream. You see, so use these stem cells are used for several reasons. So allow the administration of high-dose systemic chemo and radiation, which would be lethal otherwise. Of course, if you keep giving chemotherapy, high-dose radiation, and you don't have any stem cell to boost the patient, your patient will die. So the hematopoietic stem cell from a donor has, of course, an anti-tumor effect, and this is the most beautiful things. So characteristics of hematopoietic stem cell that aid in transplantation that, you know, important. So the ability, the stem cell, it's what is the beauty of the stem cell. They have the ability to regenerate in the marrow. The stem cell, it's the well known, we call them, they are pluripotent, able to self-replicate, proliferate and develop, and they can develop and build the system, myeloid and lymphoid pathway. Small number of stem cells required to replicate, to repopulate a patient entire hematopoietic stem cell system. Cell ability to find their way to the marrow following the IV infusion. You give your stem cell by IV and let them play the role. They will play the beautiful role of stem cell replacement. So the type and indication of hematopoietic stem cell is characterized based on the origin of the cell source. So of course you have the autologous stem cell, you have the allogenic and syngeneic, which is from the twin donor. So the autologous stem cell is referred to stem cell collected from self, from the patient himself, to be reinfused at a later date following myeloablation or high-dose chemotherapy. So we always said, usually we always said, we should say that, not, I don't like to use auto, it's a stem cell rescue, because if, as I said, if you don't have this stem cell beside, your patient will die. And the objective is maximum cell kill that could not be done without reinfusion of the autologous stem cell. If, as I said, if you don't have, you cannot, the stem cell, and you give all this chemotherapy to kill the disease, you must have the stem cell to be infused after this chemotherapy. And of course, and in this way, the stem cells are collected prior and cryopreserved, and when the patient is ready, we will give it to him. Sometimes the autologous or the stem cell rescue is considered as a part of the initial treatment plan. Yes, we do this, and may be stored in case of relapse or persistent disease status. We do that as well, of course. So the so what are the disease? So many diseases are treated by autologous. Is of course the myeloma, non-Hodgkin lymphoma, germ cell tumor, neuroblastoma, brain sarcoma, AML, the Wilm tumor as well. So the advantages of this, it's ready access to stem cell. You know, you have your patient, you got his stem cell, you store them. So it's really very easy. It's decreased the incidence and severity of side effect. It has an early engraftment, of course, and you don't have any GVHD. So, sorry. The disadvantage of these transplants is the risk of potential tumor contamination in the infused cell, lack of immunologic GVH, so the graft versus tumor effect may contribute to the relapse, because with the allo we have this effect, and its help to the how to say, to help the patient, you know, to cure. So the allo is another business, and it's used or the allo-related, which can have a use from related donor or unrelated donor as the source of stem cell. So you have from brother, sister, or you got your unrelated donor from any other registry. So match sibling related, mismatch with haploantibody, haploidentical, match related, mismatch related, match are related. I have done so many match are related from NMDP, Zicardi, etc. Mismatch are related. We have done it as well. And of course, the cord blood also is considered as a allo. So allogenic hematopoietic stem cell, the treatment of choice with a patient with cancer who have a disease, bone marrow, or patient with genetic or immunologic disease. So we are talking about all kinds of leukemia, AML, ALL, CML, MDS, non-Hodgkin lymphoma. You have also all these severe aplastic anemia, Fanconi anemia, thalassemia, and sickle cell, and they do very, very well. You have the SCID, all these congenital diseases, neutropenia, so many immunological patients, many of other genetic and immunodeficiency disease that children can be treated with allogeneic, and they do very well after that. So the donors are identified through HLA typing. Of course, HLA compatibility is the key. This is the key in predicting transplant-related morbidity and mortality. And the patient with one sibling, has 25% chance of a match. In the US, only 30% chance of finding an HLA match sibling donor from this only brother. Being in Saudi for 35 years, so we were doing a lot of allo because we had more than 65% chance of finding an HLA match siblings. So if no HLA sibling donor available, search has to be done. So as I said, through unrelated donor a registry and or from cord blood. So the advantage, of course, of this allogenic, the replacement of diseased or damaged cell with healthy one. You have killed the disease with the chemotherapy and radiation, and then you give a healthy cells, which is a very, very, very good. So, and you got, because always remember, you will get with the allo, you will get a graft versus tumor, the GVT effect. This is the most powerful immune reaction in which the newly transplanted immune cell may react against any residual disease. This is one of the most important advantages of doing an allogeneic. And of course, so the disadvantage, and we have seen it for all those who has been doing transplant, is the acute and chronic GVHD and the complication and toxicity related to conditioning regimen, donor type, level, and length of immunosuppression, and of course the organ status before the transplant. So from the twin syngeneic twin, from the twin, the allogenic transplant, in which systems are collected from one identical twin and infused into the other following high-dose chemo. So of course, they are the same antigen. They have the same marker. So the major disadvantage is there is lack of GVL effect. So it's just like you are doing an auto, and cytogenetic study must be performed on donor, of course, to rule out if they have the same genetic marker as the patient. This is very important when you choose, when you don't have the choice and you have only this twin donor. So unrelated cord blood, this is, we were in the in the 80s, 19, we were all excited because we were doing a lot, cord blood. So it's a very rich source of stem cell collected at the time of childbirth and have the ability to induce engraftment. So there is no doubt about it. The cord blood cells have not matured immunologically. They may be used where HLA match not available, you see. So can be, and we do cryopreserve and stored, and can be stored for many, many years. This is a painless procedure to mother and baby, not needed by either after birth, often discarded as a waste. So thank you. It's all what I have to say about this. If we do not lay out ourselves in the service of mankind, whom should we serve? This is very important. Thank you, guys. And then.
Thank you so much, Rachel.
Anytime, my darling. So that's so my last presentation here. Let me just found out where is it. So our last presentation. So this is. So how can we infuse this beautiful? I'm very in love with everything related to hematopoietic stem cell anyway. So how can we infuse it? How can we give it? So the infusion of stem cells. So what we should know to provide a hematopoietic cell, either autologous or allogenic, to enable the bone marrow space to be regenerated. The cells are infused after conditioning regimen consisting of all or some of the following. So the patient has received his chemotherapy, he has received his radiation, biotherapy, or immunosuppressions, okay? And this is important, and for all the new, because I am talking at the new nurses who are going to perform their first transplant as well, so that the stem cell must not be infused less than 24 hours after the last dose of chemotherapy or biotherapy. Why? Because the chemotherapy or biotherapy can still be active up to 24 hours post administration, and it will destroy your new stem cell. And the stem cell may be infused 2 to 4 hours after the last dose of radiation. So the infusion of hematopoietic stem cell, here we are in OR, and you are to the physician in which side of the iliac crest. Sorry, two type of product here. We have bone marrow, and it's the donor is harvested. The donor or the patient can be a patient, and it's done. The harvest is done in OR, and the two physicians, they are in each side of the bed, and they will just have the needle, and they will take the marrow from the iliac crest of the patient or the donor, and it's of course it's done under GA. Here we have this beautiful lady. She's just lying on this nice bed, and it's what we call the hematopoietic. It's by peripheral stem cell. So she has two needle in each arms, and it goes through the machine, and it's what we call the peripheral stem cell. Okay. And the infusion of fresh hematopoietic stem cell, the fresh stem cell from either source are viable for 48 hours post collection. We just, we can keep after the collection, we can keep the stem cell in the room temperature for up to 48 hours. It has to be kept at room temperature, and it has to be far of sunlight. So here it's what the schema, it's show, how the physician, they are here to, each one is in one side of the bed and in the iliac crest, and they will just aspirate the bone marrow, which is the blood, and it goes to the here it will be after when they take each needle, we will just, they will go for the filtering. All the marrow are filtered, because if there is some little bit of bones, so it has to be very filtered before we will bring it to the patient. So infusion of fresh stem cell. So the pre-medication patient, pre-med patient as necessary. This is, we always pre-med the patient. We use a wide bore lumen catheter to infuse the cell. We always use Hickman catheter or permacat for when we have, or the permacat is used when we are doing autologous. If central line is not available for some reason, we were not able to have the line in place, the Hickman line in place, as much as you can try not and to have your line. It's, you have to use a very big peripheral cannula, 18 gauge, but I just don't want to think of, it has to avoid. So PICC line or temporary CVC must not be used. This is a very fine, very small line, and as the diameter is very small, and it can take a long time to infuse your stem cell. It might get blocked, and especially with the bone marrow, as it contains fat cells. So it's very difficult to have a transplant stem cell infusion with PICC line. So the infusion of fresh stem cell use an IV given set tubing. Also, I will send to you the material, it will be on with this included, how to what to have ready for the tubing, how it looks like. And it has to be free flow, and has no filter, and it's primed with sodium chloride. You have always to check your blood return on the device you are infusion the same through. You need to check your device, and you connect the IV tubing with 0.9 sodium chloride and let it drip slowly to keep the line patterned. Check the your stem cell always with another nurse. The stem cell cannot be just given. You will take it from the lab and you give. It has to be always two nurses who will check. You have check at the lab when you pick up the stem cell, and at the bedside it has to be checked by two nurses. This is a very, very clear policy and guideline of the stem cell infusion. And the infusion of stem cell will start infusing at 1 milliliter, okay, and we increase up to maximum of 4 milliliter per minute. And of course, and we will monitor the vital signs pre-infusion, and then to me, I always do, half hour, 15 minutes, and then we go to half hourly. If patient remains stable, we may increase to hourly, but you are always beside your patient. And just remember you are beside your patient, okay? At completion of the infusion, flush tubing very well with your 0.9% sodium chloride. Always really flush all your line. No stem cell will remain in the tubing. And then you continue to monitor your patient very quickly from 4 to 6 hours. The infusion of cryopreserved stem cells, the stem cells are harvested before the infusion date. We talk about this for the auto. The patient has been harvested before, and we have cryopreserved his stem cell until he was ready to the autologous. Then the day of the stem cell transplant come, the stem cell are torn. So the guy from the lab, they will bring the cassette where the stem cell has been stored at the body. They will bring this cassette where your stem cell are there at the and it's at body temperature in a bath of 37 degrees centigrade. And the cryopreserved stem cell must be infused within 30 minutes of thawing. That's why we do always the thawing at the bedside of the patient. And there is, the patient and the nurses often, they suffer from, the DMSO. This is the one of these ingredient they put to preserve the stem cell, and it's you will smell it, so that's so here you have your where they put the stem cell in this bag, and then they will take it. It's a cassette. It's they preserve the cryopreserve in this place. Okay, so infusion of cryopreserve. There is another here also. Thorwin is my friend who did this, so how we prepare the patient, how did we, the patient to take his stem cell, we have given him GCSF for 8 to 10 days, then we have taken his stem cell, or we can also do bone marrow, and then it's going to be isolated and taken and to the cryopreservation. Then The patient will come. Sometimes we will give him the condition in his chemotherapy regimen and radiation, and then we will bring the stem cell to the patient and then the supportive care. Troubleshooting. So this is if the patient reacts during the infusion of stem cell. So this is, we are talking here about auto, as this is so we stop. So the patient, he makes a shortness of breath and not feeling bad. So we just stop the infusion. We do not disconnect. We just contact your physician. And we will just take some time and recommence infusion, and we will just go very slowly. And the cryopreserved cell patient, usually they react to these ingredient. It's we call the DMSO, and it's very difficult when at the beginning when you start doing the auto transplant. It's very uncomfortable. It has a very back test in the back of their throat, the patient. So we give them usually, as we were giving them fresh orange peel or sucking a candy, it help a lot. And we add an antiemetic to pre-med to help with nausea as well, because it has this effect. Thank you, guys. Thank you. I have here.
Thank you so much, Reggie, ma'am. Wow. Wow. I'm so glad. Like, this topic was well attended to. Thank you so much for this teaching. It was really comprehensive, and in fact, it was exhaustive. Thank you so much. So
no, I was just worried because I have this sore throat and I've been coughing.
yeah, I see. So sorry, ma'am.
No,
so sorry.
no,
Do take care.
No. I'm happy you got it. Okay.
We did.
Yes.
All right. So for every question about this topic on the HLA that she took first, and then the hematopoietic stem cell transplantation from the types, sources, indication, and then the infusion of the stem cells, please put your questions down in the question and answer session. We'll take everything at the end of the whole presentation. So I'll be bringing up the next speaker now. So the next person to give us a lecture is another seasoned transplant nurse, Mrs. Eugenia Trigoso. So she's the WBMT Nurses Group Committee Vice Chair, and she's currently a JC Inspector. She's an active member of different nursing groups in different societies related to oncology or bone marrow transplant, such as the European Society for Blood and Marrow Transplantation, amongst others. Her credentials include nursing degree and a master's degree in ethics. She has rendered volunteer work in India, as well as nursing job experience in Geneva, Switzerland, and currently in Valencia, Spain, as a university lecturer and a nursing coordinator at the University of Lafayette Pediatric Transplant Unit. Despite her absence due to some unforeseen circumstances, I would like to thank and welcome Ms. Eugenia Trigoso for sharing with us her valuable time and extensive knowledge on quality management through her topic related to the role of hematopoietic stem cell transplant nurses. So we're going to be watching the presentation now. Let's listen, and do not forget to put down your question in the question and answer session. Everything is going to be taken afterwards.
Good afternoon. My name is, as Reggie introduced me, my name is Eugenia Trigoso, and I work in Valencia, Spain, in the Hospital, University and Polytechnic Lafayette. My talk this afternoon is about the roles of the transplant nurse. And most important, what is the role of the transplant coordinator? A short introduction about our topic, we have to think that the well-defined pathway, together with a professional development strategy and specialist training opportunities, can be very effective investment in the continually evolving specialty where nurses are pivotal to patient outcomes. The importance of a well-equipped, professionally educated, and knowledgeable and competent workforce is critical. But how the nurses is going to be, how has been the evolution of the education in nursing? We have to think about that the competencies and skills that add value to the nursing profession are an evidence-based practice, empathic communication, and other broad range skills such as critical thinking. All are necessary in order to develop the profession alongside the constant change in the health system and the improvement of the quality of care. We have to be aware that nurses have successfully taken on the role of improving communication for donor mobilization, collection, and liaising with the staff of the processing facilities. As the WHO said in 2020, they said in the state of the world's nursing, we have to invest in education, jobs, and leadership. But what more about the nurse's role in bone marrow transplant? Regardless of the stage of the hematopoietic stem cell transplant pathway that nurses deliver care to patients, they should be aware of the complication in order to play a role in prevention or early detection of illness, such as sepsis, dehydration, electrolyte imbalance, and organ dysfunction. We have to take appropriate measures to minimize adverse effects and deliver prescribed treatment. Also, we have to be aware of the care of central venous access device, graft-versus-host disease, veno-occlusive disease, and too much more things that we think. We have to think about the pain control, vomit, mucositis, etc. If we talk about the advancing clinical practice nursing in hematopoietic stem cell transplant, the advanced clinical practice may be ward or outpatient-based, will usually have prescribing, admission, and radiology rights, and will diagnose and manage patients alongside medical colleagues. The aim is to improve patient care through medication management, patient and staff education, implementation of protocols and guidelines, and developing quality improvement initiatives to improve outcomes. And what more? We have to talk about the role of the transplant coordinator. The transplant coordinator is responsible for the preparation of patient and donor in a complex process that requires an expert level of communication and planning. Many transplant coordinators are nurse specialists who focus their role on the individual needs of the patients and families. And what more? The transplant coordinator provides a high level of care and management with explanation of complicated and complex tests. The transplant coordinator also will participate in specific or advanced nursing practice, bone marrow sampling, HLA typing, and transplant recipient care. Ensure that a suitable source of cells, autologous or allogeneic, is available. The transplant coordinator also supports the patient with verbal and written information and educated them about the whole process. Don't forget that the communication they have some important principles. An effective communication is a communication between two or more persons wherein the intended message is successfully delivered, received, and understood. Communication is made by correct, complete, concrete, concise, consideration, courteous, and clear. What more about the transplant coordinator? The transplant coordinator may also take care of the donor, arranging tissue typing, and will liaise with the apheresis or bone marrow harvesting. The bone marrow harvesting team to ensure a smooth process. And also they have to take care about the sibling donors. They sometimes may often have additional anxieties to that of an unrelated donor, and support from an experienced transplant coordinator is vital. It's involved in the creation of information tools for the patient and for the donor, which are evaluated in order to have an accurate knowledge of patient needs. So, what more is the transplant coordinator's task? The transplant coordinator has to facilitate the teamwork, facilitate communication, assure ongoing of quality management system, document control, document review, policy shocks, identify incident and errors, corrective and preventive actions, implement action with team, the follow-up, the risk assessment, the forms and records, outcomes, analyzing data, audits, training and competency, and a long list. The transplant coordinator is also responsible for the discharge criteria. The discharge criteria include the patient should be engrafted, that means they have to be more than 0.5 neutrophil, a febrile, no significant infection or treatment-related complication, without signs of bleeding. The patient should be able to take meds for oral, no pain, or well controlled. Some message to take home. Nurses are vital component of the transplant team, complementing their other roles in the team. Continuous modification and development in treatment undoubtedly influence this highly complex but highly rewarding area of nursing care. The Future of Nursing 2020-2030 report recommends that by 2021, nursing education program, employers, nursing leaders, licensing board, and nursing organization should initiate the implementation of a structured system and evidence-based intervention to promote nurses' health and well-being, especially as they take on new roles to advance health equity. Thank you. We have to handle it with the teamwork. Thanks a lot. Open for your question.
Thank you so much, Eugenia, ma'am. Thank you so much. Thank you for highlighting the inestimable role of nurses, being the transplant coordinators and working as a team. Of course, we all know that we need to work as a team to be efficient in carrying out our duties effectively. So very quickly, I'll be taking a few questions and we'll be getting answers from our panelists. Okay, so first, we have a question. Can HSCT be done to a sickle cell disease patient? Okay, so I'll allow Regina to answer
Yes,
this
for
question
this, of
first.
course, you remember Noof has presented this. Of course, what I have been talking also, it's for the sickler as well. It's an allogenic, of course, it's applied to sickler. Because there is a question here. It can be done for sickle cell, of course. Yes, it can be done for sickle cell. Yes. What is the question? I saw it somewhere here.
Yeah, that's the question. So recall that our last webinar was about sickle cell disease and transplant itself. I mean, sickle cell disease is a go-to disorder for transplant, right, ma'am?
Yes, it's a teaser. Yeah.
All right.
Yeah.
So the next question here is when can the central line, when can the CVL line be placed? Is it during the conditioning or before infusion? Like when exactly should the CVL line be placed along the line of
blazing, and to everyone, you have, when your patient he's cleared, he's been admitted for his transplant, and for everybody to be comfortable, it's we place the Hickman line before the chemotherapy. As much as you can, it's better to have your Hickman line placed in advance. You give your chemotherapy, and it will be there when you will bring your stem cell. This is a very, very important message from me, because it's so comfortable for you. It's for the patient and for you guys as well. So to have your Hickman line in place.
Okay.
Yeah.
Okay. So does that mean it's safe to have the Hickman line in place before the infusion, even if the conditioning regimen is beyond 14 days?
You see, when you wait too long, you give your chemotherapy. How you are going to give your chemotherapy? On PICC line, how? So the patient, he's got neutropenic, he's not well. So that's why I am always saying, please, as soon your patient come in the unit, please place his Hickman, and then you give his chemotherapy, and then you will give the stem cell. Just remember, it's very heavy, the chemotherapy. He's going to be sick, and then you will take him to OR and to put the line. So he's not well. It's better to do it when he's okay, and then you give your chemotherapy.
All right.
Yeah.
Thank you so much for that response.
Yeah.
And so another question here is, someone is asking, what is the difference between HSCT and HBMT?
So I don't know, to tell you, I've been reading this, what he's mean by HBMT. I just would like to ask Martin, his name is Martin's, what is HBMT? I don't know what is hematopoietic stem cell transplant, yes, but HBMT, I don't know what. Can he write it all? I don't know what he means by HBMT. I don't know. Bone marrow transplant? I don't know.
I guess he's confused between both terms because we interchangeably use HSCT and BMT.
That's
So I guess it's both terms that are really, the H shouldn't be at that BMT, I think
yeah,
so.
that's, you know, I remember this long time when we started with the hematopoietic stem cell, etc. Everybody, there were confusion because we were just getting out of the marrow, and you know, so maybe it's he's thinking of this.
Yeah.
Yeah.
All right. So if we can get some clarity from you, Martins, if you're there, we would appreciate that. So I'll take the next question very quickly. Someone's asking if there is any medication that should be given before transfusion of stem cells.
Yes.
So I recall that during the presentation, you clearly said that pre-medication should be given. But to answer this question, I would like you to probably break it down a little more. Let's just have some classifications
You
of those.
see, you know, I am glad you have, there is this question, because we are gonna record them, and we will answer, because I have prepared some guidelines to be put with the presentation. What, you know, you should know, the pre-medication, you know, the Hickman as well. So that it will be all there with the presentation. It will be given to Romel and Vera, so it will be on the presentation too. So we will, it's just a small guidelines for you how to give the stem cell, and when there is reaction, what you should have beside the bed, if there is, because you have always to have some medication ready in case of reaction. So I made some small guidelines. You will have it with you. In the website, it will be there with the presentation. We will add them to the presentation. Okay?
Thank you so much, Mom. You did justice to the question I just asked and the question I'm about to ask. Because there is another question there about a reaction. What if the
Yes.
patient reacts to the cells? What can be given? What can be done?
Yes,
Thank you
that's,
so much. It
you
feels so
know,
good to be around people with wealth of experience.
we are so aware. Most of you guys, some of you know, they have done some transplant, and some they have not done. So that's why I have prepared, as I said, small like guidelines, because in the room before you start your transplant, you have to have, you know, some medication ready. You have to have your medication, which is the pre-medication, which is the cortisone, etc., to be given before. And you have to have also, you know, in the plateau, just beside the patient, medication ready to be given if the patient got reacted. So this is all written in a small guidelines, and you will have it with the presentation. Okay?
All right, thank you so much. We'll look to that. So there is also another question. You talked about the cryopreserved cells. Cryopreserved cells. So we want to just clarify that in a situation where there is no cold rate freezer, how do you cryopreserve the cells?
Sorry, can you repeat, Blessing? It seems very important question.
Yes. You mentioned cryopreserved cells, transplantation of cryopreserved cells, especially for autologous. Yeah, so we want to confirm, in a situation where you do not have a cold rate fridge, like a cold rate freezer, how do you cryopreserve the stem cells?
Yes, no. So this is a very good question, and a very important question. Yes, there is many countries, because the cryopreservation room is very important, and it's not all the
Sorry, ma'am.
countries,
So sorry.
all the countries, they don't have it. They don't have it ready. So I know some, you know, mainly in the African continent, they do mobilize the patient, and they don't have the ability to cryopreserve, so they just do it before, on 3 days before the transplant. They will keep it, you know, in a safe place, and then they will infuse the patient. I know this, you know, because I have some country in Africa, especially in Algeria. They have written a lot of paper. They have done a lot of transplant, and they don't have cryopreservation, and they infuse the patient at once. Yes, 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 they do. Can be done, what I'm saying.
So, I mean, this is very important. I think we need to take
It's very,
information
very
for that
important, and
out of it.
yes, it's very important to know that we do. There are many countries they don't have, because it's very expensive, and it's need technology. It's need a highly trained technician to do this. So some countries, they are doing autologous without cryopreserving the stem cell. They just get the stem cell from the patient, you know, but of course you cannot take the stem cell and let them for 10 days. So they have usually, I should have get prepared to this, you know, I should have think about it, because this is important, and it's done. I know in Algeria, Tunisia, they are doing a lot of auto transplant without any cryopreservation. I will get the protocol for you, how they do this. I will attach it. I will attach it to the presentation. This is very important. I should have think about it. Yes. Sorry for
Thank you
that.
very much. Thank you so much. So sorry.
No,
So
no,
sorry.
but I should have thought about this. Yes.
All right, ma'am.
Mm.
Thank you so much. We'll be looking forward to getting the presentation and the documents you want to attach for our further
Yes,
learning.
it will be all attached to the to you. Where is
So one more question here. Someone's asking that in the organogram you drew out for us, it seems like the stem cell is going from the OR straight to the patient's room for infusion. So at what point does the stem cell move to the stem cell processing lab?
no, from OR, it goes, you have seen, you know, when we do bone marrow harvest, we have always a technician from the processing lab who's there waiting, you know, because the physician, we are take the bone marrow, we are filtering it, of course, at the OR, because we have a special set for the bone marrow harvest, and it's taken by the technician from the processing lab. He will take it. It has to go through the processing lab, because they will count the CD34. They will place it properly. Then from the processing lab, it go to the patient's room.
Okay.
Nurse, for us, how we were doing, you know, so the nurse was going to the processing lab, and we will take the marrow from the processing, where we sign, you know, all the things over there. So this is very important. Yes, you are right. Always the processing lab, just remember, they are always involved with the stem cell. Either it's a marrow or peripheral stem cell. It always goes the peripheral stem cell to the processing lab, where they will count, they will They will check the stem cells. They will give you the right CD34, how much you have collected. This is very important. The processing lab has played a very major role in the hematopoietic stem cell transplant. Yes.
Yeah, okay. So how long does it stay in the processing lab before it returns to the ward for infusion into
No,
the
it doesn't. Usually we go from OR, let's say it's a marrow, it taken to, to processing, from OR to processing. It takes less than 2 hours. There is no less than 2 hours, they count. And then after that, we will go and pick up usually it's really very well done, and it's done very quickly. Yes, less than
okay,
2 hours.
less than 2
Yeah,
hours.
yeah,
All right.
less, very less. And when it's peripheral stem cell, from the pheresis room, it goes to processing lab. They process. They take the sample for verification for infection, etc. CD34, and the bag will be ready. You will go, your nurse will go to pick it up, or the technician. It's all depends how you work, and it's taken, and it's very less than 2 hours, much less.
Okay.
Usually,
All right.
your team, your bone marrow team, we are playing a very good team. The blood bank, you have the OR or the apheresis, we have the blood bank and the processing lab. This is 4 units where they work very, very closely with each other. We just cannot think of transplant without these people, blood bank,
Yeah.
processing lab, the unit. This is very important.
Very, very.
Yeah.
Thank you so much, Mrs. Reggae. We really appreciate this lectures. I believe that all questions have been properly answered.
I
So
hope everybody
can-
was happy